Dr. Boon, for the kind introduction. So today I will talk about a little different endovascular first in the acute type A aortic section, and I give to thank again for Professor Ur to give me a chance to be here to sharing and learning about from the all of my teacher. So this is my hospital, the Việt Đức Hospital. It's the oldest modern hospital in Hanoi and focused on the surgical activity. And my center is the oldest center of the cardiovascular etiology series in Vietnam. So I present my case today. It's a male patient with a 73-year-old with a complaint about the abdominal pain, very sharp, with history of the hypertension, with the arm lock conversion, is a good control, no DM, but one day before the admission to the hospital. Okay, I continue now. The patient had abdominal pain and nauseous and vomiting, and we try to examination. This patient is conscious, no fever, but no fever, tenderness in the abdominal. Rectal exam is no blood. Coronet is a low foot. We will use this patient with a with a little contraction in the SpO2 99%, but blood stat with serum lactate with a 5, with a renal failure, and proBNP is more than 600 and very high of white blood cell. So this is a CT scan. You can see that this patient maybe had to type A dissection with a malposition from to the mesenteric, from to right kidney, and to the both limb inside, because the true lumen is very compressed by the full lumen. So you can to focus in the CT scanner again. You can see that you can show that maybe to the intraimmunotium very near the X, and maybe retrograde from to type A dissection with a IMS for type A. And you can see lower, very compressed for celiac. You can see nearly occlusion for the NSFA and right renal, and most of the true lumen from to abdominal and to both sides of limb might be very ischemia. So I say it's a type A aortic dissection with a TMM, TA, E2, and M positive, with the malposition multi-organ from to the mesenteric, right renal, and the both limb ischemia. So I try to calculate to the perioperative risk may be very high. I discuss with the cardiovascular surgeon and maybe very high risk patient, and a little difficult to the approach for this patient. That's this patient. So it's a borderline of Vietnam. So don't have enough to the economic to do try to something very high risk. So what should we do? So we can to come back again to the guideline from to the EATSTS, STS. We can see that this patient is a complain a lot about for the malformation. So if patient we have to visceral malformation by maybe endovascular first approach can be justified before you can to open for the proximal landing zone for this patient may be better. If this patient don't have to the rupture, don't have to the some more evidence of the rupture in the ascending aorta. So again, you can see to from to the American Heart Association the same. This patient we had a type A or type B, but we had a mesenteric or renal malformation. Maybe it's the first time treatment. We try to endovascular first for the penetration to keep to the blood flow to the SMA or the renal better. After that, we try to the keep patient stable and transfer patient go to the open repair. Again, you can see the ESC from the 2022. We had guideline from the management of the aortic and peripheral. You can see that in patient with the acute type A, if a patient with a mesenteric malperfusion, maybe immediately invasive and angiographic diagnosis, and after that you do the endovascular first. After that, you can see aortic surgery, open repair, but special in the aortic center with the exercise and should be considered. So I try to read and recommend to some management patient with acute IA or some center in the Europe and to the US, or for to the 20-year experience, say that maybe you can approach for this patient maybe by to the endovascular first. So it's for me, I try use the fenestration by use a balloon. to make a new hole to the between the true lumen and full lumen. And after that, I put the stent above to the celiac artery, try to open to the true lumen first. So this is my case. When I see that when I try to use the angio form to femoral, especially in the right femoral, you can see that the true lumen may be compressed, and all of the SMA, celiac, and right renal may be compressed too much, not enough to blood flow. That means the malpopulation. So I use a balloon from the true lumen go to the full lumen, try to open with a peripheral balloon, maybe 9, after that 10 and 20 to the open, make a hole, a big hole enough for this patient to the more blood flow to the go through the for a true lumen. And after that, I use a non-band stand from to Valiant Computer in the from the Medtronic, because in Vietnam to the I use a non-band stand maybe enough to the economic the patient can pay. So you can see after I use the Valiant Capital from to the uh, above to origin of the celiac, you can see the open and almost of the blood flow to the bone SMA, right renal and the celiac and the both to the limb may be open and good enough for this patient. I transfer patient to the ICU without to the intratube, and I check again with the CT scan after 48 hours. Everything is stable. This patient is stable. Maybe the abdominal pain is reduced and to the stable hemodynamic. So you discuss with the cardiovascular surgeon and transfer him go to cardiovascular surgeon to do the second step with a fast frozen effort trunk modified with technique. I use the Valiant catheter with non-bear for the frozen effort trunk 28, 115 millimeter below for the proximal landing zone. You can see that after you can friction on the open repair for the proximal landing zone. So that is problem when you try to use the fast and the friction and below. All the way the stand grab is the aortic arch. We had the kinking. So I use the third time I use the balloon to the open to the from the aortic arch with the stand to open, maybe reduce the pressure come here. And I try again when to check angiogram. I can see that when I take for the big hole for above to the celiac, I had some problem with the endolic tie error. So I use a vascular duct from the true lumen go to the full lumen to occlude total with the full lumen with the flux ACA from 22 millimeter. And I see when I check angiogram, everything stable, non-endolic, and the patient and the normal and transfer go to the ICU to treatment. So it is some experience. I think it's a little experience, but I think it's a new approach. Maybe in the university hospital, you can try for the 3 patients with a type A aortic dissection with the organ malformation. All the way use the TIVA with no bear. I don't think it's a bear 10. I had some maybe to damage to the lumen and to the full lumen, lumen, maybe a rupture aortic dissection. Some case I use a cover stand for the both iliac, some case I use the stand for the left renal arteria, and some case I only to use the penetration with the balloon. But I had one case, we had to die that because the rupture after 28 hours. What that means is for me experience when I do the TIVA with non-bear for this patient like type A aortic dissection, I don't want to put to TIVA maybe more zone 1 or zone 2, only cover to zone 3 with the possible you can to open to the true lumen with the more blood pressure to the MA for the renal and the both limb. So I think in the most patient with the acute type A aortic dissection, maybe open repair remain the recommend approach to prevent the death. But this patient with the malformation type A, sometimes very difficult. You can choose to the open repair. I can choose the endovascular for this patient, especially in some developed country like Vietnam, because we had to some problem in the divide, some problem with the economic. So I think for the patient with a stable, it's a no rupture, no tamponade, progressing is a malformation syndrome. You can stay approach, like in my experience, you can endovascular first, open to the good blood pressure to the organ dysfunction, and after that you can delay open aortic repair, maybe more beneficial. Thank you again for the attention.